The views expressed in this podcast are my own and those of my guests. They do not represent or reflect those of UCSF Health or my professional and clinical roles there. The content is intended for informational purposes only and is not medical advice. Please consult a qualified healthcare professional for specific medical guidance. Welcome back to In the Loop with Nadja Wlasiuk. Today, we're diving into something I see nearly every day in practice: pacemakers, the small life-changing devices that keep the heart beating in rhythm when its natural electrical system can't keep up. Whether it's from age-related conduction disease, sinus node dysfunction, or for atrial fibrillation, pacemakers can restore energy, prevent fainting, and quite literally give people their lives back. We'll explore what a pacemaker actually does, how it knows when to step in, and the differences between single chamber, dual chamber, cardiac resynchronization, or CRT, and even leadless pacemakers so small that they look like a vitamin. To help us unpack all of that, I am joined by Lauren Parr, a biomedical engineer and clinical specialist in cardiac rhythm management. She's IBHRE certified as a cardiac device specialist and a graduate of the University of Missouri-Columbia, with years of experience in the electrophysiology lab supporting device implants, troubleshooting leads, and educating both clinicians and patients. Lauren brings an engineer's precision and a clinician's heart to this conversation. And together, we'll translate pacemaker language into plain English. So whether you're a nurse, a provider, or someone curious about how these devices keep the rhythm of life steady, this episode is for you. All right, let's get in the loop on pacemakers. Lauren, thank you so much for being here and sharing your wealth of knowledge about pacemakers. I am so excited about this episode because it's right in my wheelhouse.
I'm excited to be here. Thanks for having me.
Of course. You are technically a biomedical engineer for a major medical device company. How did you get there?
I have to thank my dad for how I got here. My dad and I both work for the same company. And so I had my first EKG when I was 9 because he hooked me up to the pacemaker programmer. He had tried throughout all of my college career to get me to shadow him. And, my job is so cool. You should definitely give it a try. But of course, I could not do what my dad does. So I graduated with my bachelor's and then went to grad school because I still didn't know what I wanted to do with my life. I knew I wanted to be in healthcare.
Mm-hmm.
Both of my parents are nurses, but I knew I could not do that. That everyone that is a nurse is an angel on this earth. They do too much, and I just knew that wasn't for me. I couldn't handle it. I wasn't cut out for it. So I finally decided to shadow him.
Mm-hmm.
And see what his day was. And it turns out that being a pacemaker rep is really cool.
Yeah.
So I agreed to give it a shot and then got the job. And here we are.
Here we are. That's amazing. And you actually had a lot to do with my education in devices because when I came to the West Coast, I was pretty deficient because the hospital that I worked at, the reps came in and checked all the devices and I never really had to do it. I always called the sheet that they would write on pacemaker ease because I didn't really understand it. So when I came out here and I had to have more knowledge of that, you really were helpful in that. And I appreciate it so much.
Well, you did great. So it wasn't just me. You worked really hard and paid off.
Well, thank you. For listeners who aren't familiar, what is a pacemaker?
A pacemaker is a device that gives you a heartbeat. So it keeps your heartbeat from going too slow. It can also provide synchrony to your two ventricles.
Those are the bottom two chambers of your heart.
So it consists of a device that sits in your chest sometimes, which we'll get into. And there are leads that go into your heart and they can deliver electrical impulses that can make your heart beat.
Okay, great. And what do we call that device? What are the different names that it can be called?
It can be called a pacemaker. It can be called a generator. It can be called a battery. If you're in the lab, it can be called a can.
Yeah. Okay. Great. Yeah.
So it can be called a bunch of different things, but they all mean the same thing: the device that makes your heart beat.
Yeah. Absolutely. Do the leads go inside the heart or outside the heart?
It does depend. We can do both. For most of the population, though, they go inside the heart.
When would they go on the outside?
That could happen if you're too young to get a transvenous device. Transvenous is when they go inside of your heart. So that only can happen if you're done growing.
Okay.
And so if you need a pacemaker and you're 3 years old, my youngest person was 4 hours old.
Wow.
Then you get an epicardial device, is what it's called.
Side of the heart. Yeah.
Exactly. And that's more involved of a procedure. But that's why you'd get that.
Okay. So where do the generators go then?
For children, they go in their abdomen.
So what a pacemaker does for the heart is it generates that heartbeat impulse, and it can also synchronize the two bottom chambers of the heart.
Correct. The electrical system divides itself between the two ventricles, and if one of those is not able to communicate to the other, then we have to put a different kind of device called a CRT, which stands for cardiac resynchronization therapy. We give you a CRT device, and then that can pace both of your ventricles at the same time to hopefully give you a more physiologic heartbeat.
What does a pacemaker do? What can it see and what can it do? Because I think a lot of people have this misconception that it does more than it does. So it's a pretty simple device, isn't it?
Yeah, exactly. So a pacemaker at its base can do two things. It can pace and it can sense.
Okay.
And sensing comes into the patient's native heartbeat. The pacemaker can keep you from going too slow, but it can't do anything about you going too fast. So the pacemaker is always looking. It's not always pacing. It only paces when it needs to. That's to preserve battery, to preserve cardiac function. We don't want someone to pace unnecessarily. A device has different parameters that we program, so we can set the floor of where we'll allow the heart rate to go. Right. It can go down as low as 30. It can go up to 100, anywhere in between. So the pacemaker is looking to see, is the patient having a heartbeat? Yes, then I don't need it to do my job. Is it having a heartbeat? Do I need to do my job? No. Then it looks and it says, oh, there is a heartbeat that's not coming in. I need to work. I need to do my job. I'm going to pace here.
And then after it paces, then it starts looking again to see if the heart's natural conduction continues. And if it doesn't, then the pacemaker just paces. So people sometimes don't pace all the time.
Exactly. So just because you have a pacemaker doesn't mean you're dependent on the pacemaker. Even if you use it all the time, you might not be dependent on your pacemaker.
You might just have a really slow underlying heart rate that was making you feel like not so hot before. And now that you have a robust pulse, you feel a lot better. So talk to me about what types of pacemakers there are. Like, how many different pacemakers are there?
So there are all different types of pacemakers for different reasons. The first type you can get is a single chamber pacemaker. So that means there's one lead in either your atrium or in your ventricle. In the US, we don't do a lot of those one lead in your atrium pacemakers. That's more common in children. The reason you would get a pacemaker with only one lead in your ventricle would be because you have atrial fibrillation, and we don't need to pace or sense the atrium in that instance. We just need to provide a heartbeat in the ventricle. And I will say, too, sometimes people don't realize that the heartbeat from the ventricle is the one that provides a heartbeat.
Right.
So if you have a bunch of heartbeats in your atrium, they are not the ones that are giving you that pulse that you feel.
Right. And that's exactly why you just need the bottom chamber to pump. And that's how we can ignore that top chamber with atrial fibrillation. And in a later podcast, when we talk about advanced therapies for atrial fibrillation, that's one of the options that we have. It's called an ablatant pace, where we just knock out the heart's ability to beat on its own. And we pace with a pacemaker so that it's not going crazy fast all the time. But we'll go into more depth later. To be continued on that one.
The reason you could have what's called a dual chamber pacemaker, or a pacemaker with two leads, is because either the connection between the top chamber and the bottom chamber is not working as efficiently as we would like, or the top chamber needs to be stimulated more. So the top chamber, your atrium, is what's called the timekeeper for your heartbeat. So if you exercise and you can't get your heart rate up like you should, or your heartbeat is too slow and you have symptoms because of that, but the connection between the top chamber and the bottom chamber is still good, you would still in that instance get a dual chamber pacemaker.
Okay. What are some symptoms that people would feel if their heartbeat was too slow?
You could feel lightheaded or dizzy. You could pass out. You could feel numbness or tingling in your extremities.
You had mentioned earlier that when you're exercising, you can't get your heart rate up and up. And that's called chronotropic incompetence, which is a big fancy word that just means what we described. But I'll have patients who come to me that are endurance athletes, and they used to be able to ride their bike really fast and hard, and now they can't, and they just feel like pooped. And it's because their heart just can't keep up with the activity that they're doing. So they are great candidates for pacemakers.
Exactly.
Okay, so we talked about single chamber, we talked about dual chamber. What's next?
You could also have what's called a CRT pacemaker, which means you have 3 leads or 2 if you're in atrial fibrillation. You don't need to have that extra lead in the right atrium. The 2 chambers in your ventricle provide synchronization, and you need synchronization to pump enough blood through your body. So we can tell the pacemaker at what time exactly to pace both of those leads so that you have the most normal physiologic heartbeat that the pacemaker can provide.
Right. And the reason that we would want to do that is if you pace from the right side, which is where the typical dual chamber pacemaker lead is, it's in that right ventricle. If you pace from there a lot, sometimes it becomes dysynchronous because you're stimulating that right side. The left side doesn't catch up. And when that happens, it can cause heart failure or pacemaker-induced cardiomyopathy, which is a big phrase that means that the pacemaker is making the heart weak. So in that case, then we would evaluate them and say, oh, hey, we need this extra lead so that both the left and the right can pace together. For the healthcare providers that are listening, how you can tell if this therapy is working is on an EKG. You would want to look at the QRS and make sure it's pretty narrow because that's what we're trying to do. And if our QRS is wider than 150, that's where we would want to tighten that up and add an extra lead to be able to have that left and right kind of synchronized together. Because if not, if you're thinking about how the heart's beating and we're talking about the 2 bottom chambers of the heart, if the right's kicking off first and the left has to play catch up, you can see how that would be really wonky and dysynchronous and kind of like a limp, like your heart's limping along. If we put a lead in that left side and then the left and right, like Lauren was describing, they go together, then everybody's synchronized and it's like the dance is beautiful and it's all together and we got synchronized swimmers in the pool doing exactly what they're supposed to do. And I've seen patients who have had really weak hearts from pacemakers once they get that extra lead and their heart's pumping in time again together. All that improves and those symptoms go away. So Lauren, I know there's one more pacemaker that we didn't talk about. You want to tell us about it?
It's my favorite type of pacemaker. It's called a leadless pacemaker. And believe it or not, there are no leads on this device. So that means that there is a vitamin-sized pacemaker that goes inside your ventricle or your atrium, depending on where the pacing need is, and it can still provide that stimulus. They're not indicated for everyone that needs a pacemaker.
What are the reasons that you would get a leadless pacemaker?
Great question. There can be quite a few. One reason could be because the veins that we need to go through to put those pacemaker leads in are too small to fit the pacemaker leads through. That can happen because you're born that way. That can happen because you had radiation on that side, because you're on dialysis, or it could be because you have a high infection risk. And leadless pacemakers lower your risk of infection by a significant amount. So it can be also the safest thing for the patient.
So we talked about the whole range of pacemakers, all the way from a leadless pacemaker that's the size of a vitamin to, I call it the Cadillac or Ferrari of devices versus the CRT, which can have up to 3 leads, and then just your dual chamber or single chamber pacemakers. Is getting a pacemaker a major surgery?
When you're in the room watching it happen, it doesn't seem like a major procedure. It's not open heart surgery most of the time. You make a small incision in the chest, and then that gives the physician access to your veins to put the leads in through. We put the pacemaker in that pocket that was created, sew it back up, and you're good to go.
Yeah, so the patient is not typically under general anesthesia.
Correct.
Routinely. Sometimes they are, but a lot of times it's just procedural sedation. This is how I like to explain it, and of course I'm not in the room like you are, but I have to talk to patients before they get it. So I like to tell them that the physician will make about 1 inch to 1.5 inch incision on their chest wall, and then they'll create a pocket. And I'll say that the pacemaker is about the size of an Oreo cookie. A little bigger maybe, depending on...
No, that's about right.
Yeah, an Oreo cookie. And so that's where the can or the generator or the battery or the pacemaker, so many different words that mean the same thing, will go. And then they thread the leads through the veins into the heart. We typically use dissolvable sutures, and then the outside, what we like to call the pocket, that incision will have skin glue over it. So it's a minimally invasive procedure. It does have risks, but less risks than like open heart surgery where you're cracking open the sternum and things like that.
So we talked about when you first get a pacemaker, but we also need to talk about when you get the battery replaced. And we use the phrase you get your generator changed or your battery replaced, but it means you get an entirely new pacemaker. You want a new pacemaker because technology is constantly evolving and you want to have all the latest bells and whistles that come with the newest device. A pacemaker has the generator itself, and then on top of it is what we call the header, and that's where we plug those leads in. And they get plugged in and screwed on with a screwdriver.
Yeah, it's just a screwdriver.
And connected to the device.
A sterile screwdriver.
A sterile screwdriver. So, as long as those leads are functioning appropriately, and typically leads last longer than the device itself, then you unscrew the old device and you screw on a new one, and you use the same incision and the same pocket most of the time as well, and then you go home same day.
Yeah, and then sometimes we do have to do a pocket revision if there was something going on with it, or you had to upgrade your device and had to get a bigger device, because devices come in shapes and sizes. And in the show notes today, we'll put a pacemaker diagram and show you an example of each type of pacemaker so that you can get a good idea of what they are. That's one thing that I loved. Lauren actually gifted me a whole set of the different devices that the company that she worked for uses, so that when I'm talking to a patient about them, I can put it in their hand so they can see what is about to be implanted in them. Obviously, it's not the real device, but a demo device, so that you can see how heavy it is and how it would feel. And I think it makes it a little bit less scary for people when they actually know what it is. Like, I show them the loop recorders. I put it in their hand. I'm like, this is what we're going to do.
Yeah, it's very scary to wake up and you have a piece of machinery in your chest. It is a big deal. It's okay to feel like a major procedure has happened.
Yeah, even though we say it's minimally invasive because it's something that we see all the time and we know that the risks are very low, it's still a life-changing event. And I want to say this, actually, the credit goes to Dr. Walsh from Ascension St. Vincent's Riverside in Jacksonville, Florida. When we would talk to patients about getting devices, he always would tell the patients that these are enabling devices, not disabling devices. They're going to help your quality of life. You're going to feel so much better when you have a pacemaker.
I love the way that he said that. That's great.
I use it all the time because I have some patients who are really hesitant or feel like it's a negative thing that they're getting this device. But if you need it to feel better and to be able to function and do your daily life, it's definitely enabling you, because what's the alternative? Continuing to feel like crap or passing out all the time, or, the cool thing about your job, and I think you said once that like most patients don't even know that you're there, is that you are actually in the EP lab with the electrophysiologists, the fellows, the nurses, everybody, because you are the expert of that device. So what do you do in the lab?
So part of my job is to bring in the actual equipment.
Mm-hmm.
I provide the leads, the sterile screwdriver, the pacemaker, anything that we could possibly use for this procedure. The bags are so big, I could fit into them.
To be fair, y'all, Lauren is a little shorty. It's okay. She could fit in one of the bags.
But the other thing that I do is I help test the leads. So I am in there to check all of the electrical measurements and to provide any assistance that the other staff could use on placement of the leads. Is this an okay spot?
I'm glad you said that. I know how the leads get attached to the heart, but can you explain to everyone that's listening, do they just go in there, or how do they attach to the heart?
There's two different ways. One of them is they just go in there,
Mm-hmm.
and there are these fibers in your ventricle that are called trabeculae.
Like, to describe tuberculosis, like if you open up a pumpkin and there's strings inside and you pull those out, like that's what the inside of your heart looks like.
Exactly. So there is a type of lead that has tines
Mm-hmm.
that can fit inside of that trabeculation and hold the lead in place. Most pacemakers have a screw on the end, though, and it looks like the spring inside of a pen,
Mm-hmm.
which you tell your patients all of the time.
Yep.
And we can screw it into the heart tissue,
Mm-hmm.
and that will hold it in place.
How long does it take for that to heal in place?
It takes about 6 weeks.
Okay.
So you want to make sure that you're not golfing the next day after your pacemaker procedure. Yeah.
Not golfing, not doing any sharp jerking motions with your implant arm. I like to call it the implant arm because pacemakers are implanted on the left side of the chest, but for some reasons, we may have to implant it on the right. So whatever arm is attached to that area that is the implant arm, or where the implant is, we don't want you to do any sharp jerking motions. We don't want you reaching high above your head or far behind your back for that first 6 weeks, just so that it can heal in place. And then after that, everyth's fair game.
Mm-hmm.
Except for, well, okay, everything is not quite fair game. We don't want you to do repetitive overhead motions because the leads can be crimped by your clavicle, and the more you bang around those leads over time can damage them, and we don't want to damage your leads.
I also talk to the patient before and after the procedure. If they have any questions, I'm more than happy to answer them and just make sure that you feel 100% confident in the procedure that you're going to have that day. I know it can be really scary and nerve-wracking to have a procedure. The way that I like to think about it, though, is when I went under anesthesia myself for the first time, the anesthesiologist said, "This is new for you, but it's every day for us." And it's true. This is our job. Yep. We love doing it. We're there to provide the best care that we possibly can for patients.
Yeah, absolutely. I know we kind of talked about like activity restrictions post pacemaker implant, but I know that you probably get a lot of questions after pacemakers are put in. How do you see recovery for most people afterwards?
I would say that for most people, it's pretty easy. I see patients 1 week post-op from all of their procedures, and I don't think that they like that they can't put their shirt on the same way that they could a week ago, but it's usually a pretty easy recovery time.
Yeah, because there aren't a lot of restrictions. They can use their other arm. They can still use their arm. And that is actually one key point that I wanted to bring up is we don't want you to get a frozen shoulder after a pacemaker implant, because a lot of people think, oh, I can't use my arm at all. And that's not the case. We just don't want you doing crazy stuff with it because we want those leads to heal in place. But please use your arm so that we don't get that frozen shoulder. Lauren, can people with pacemakers still use cell phones, microwaves, go through airport security without worrying?
So I think this is very important. Yes, you can use your microwave. I had a patient that hadn't used her microwave in 10 years.
Oh.
It is okay. You can get in front. I mean, I don't know if anyone is supposed to stand in front of a microwave.
I don't know. I heard somebody say, as long as you're not hugging the microwave, it's okay.
Okay.
I don't know.
Well, what I tell when I give patients the after instructions on what they can and cannot do, I say, please don't stick your fingers in any sockets. It's just, it's not worth it. It's not going to serve you. You do need to worry about arc welding. Not regular welding, arc welding. That is a big thing.
And if you don't know what that is and you don't weld, you don't have to worry about it.
Magnets are another thing that can interfere with the pacemaker. It's a good thing. We use the magnet function in other procedures so that we can make the pacemaker blind to any of the equipment that is being used in that other procedure so that it can safely pace your heart. But magnets are everywhere. Most notably, they're in your phone, especially an iPhone. And so you don't want to keep your phone in your chest pocket.
Mm-hmm.
You want to make sure that your phone is at least 6 inches away from your device.
Okay. And that's like sitting on top of it. Like if it's near your pacemaker for a little bit, like you're moving it past it, that's not a problem. It's when it's resting right over the pacemaker on the skin, right?
Exactly. You can go through an airport just fine. We give you an ID card so that TSA knows that you have an implanted medical device. You may set off the metal detector, but it's totally safe to go through that.
Okay. And it's not going to harm the pacemaker if you go through the metal detector or the scanners at TSA, right? Okay. Can you scuba dive with a pacemaker?
You can scuba dive with a pacemaker. You do have some restrictions, though.
Okay.
And it's generally recommended that you dive no deeper than 100 feet.
Okay. Good to know, because that is a question that comes up quite a bit. Anything else that people with pacemakers should be aware of?
Induction cooktops.
Okay.
Those are pretty popular in the pacemaker population. And you need to make sure that you are a foot away from an induction cooktop. That's usually about arm's length, but don't bend over your induction cooktop.
Okay, perfect. Are there any exciting technologies or innovations coming in the next few years that you can talk about that you think patients should know about?
Yeah. So what's really cool is we have conduction system pacing for both the ventricle and the atrium, and that provides a more physiologic or normal heartbeat for the patient. And early data has shown that that can lower your risk of developing that pacemaker-induced cardiomyopathy.
Yeah, that's awesome. The first part of this interview was geared more towards just general pacemaker knowledge for everybody. And now I want to kind of switch gears with you, Lauren, and I want to speak to nurses and providers that work outside of electrophysiology so that we can help them understand a little bit more about patients with pacemakers and pacemakers in general. So what do you think non-electrophysiology providers should understand about how pacemakers interact with other areas of care, like imaging, like MRIs?
MRI is just a giant magnet. But pacemakers these days are designed to go into an MRI machine. So if you are getting a pacemaker, for the most part, in today's day and age, you should be able to get an MRI.
Right. I think again, correct me if I'm wrong, the only way that pacemakers are not MRI compatible or MRI conditional, which both mean the same thing, is if they are old and their leads may not have been MRI compatible at the time of implant, which happens to old leads, or for some reason the can isn't, or the generator, which most of them have probably been changed out by now because the batteries only last, 10, 15 years. Or here's one thing that I have seen is if the can is from one manufacturer and the leads are from another manufacturer, they are not considered MRI conditional, although that doesn't mean you can't have an MRI. It just means it's a little fuzzy.
Yeah, all of the pieces are MRI conditional. So it depends on the institution where you're getting the MRI, if they feel comfortable scanning that device.
Right, if they have protocols in place. And the last reason that you would not be able to obtain an MRI, or a patient would not, since I guess we're speaking to the providers more, is you want to ask your patients if they have an abandoned lead. Because if there is a lead that was left in place, they can't have an MRI because the lead, we can't test it, we can't watch it, we don't know what's happening to it, and it could heat up and really harm the patient.
You also need to have a functioning device. So a recent device check is needed to make sure that all of the leads are intact and functioning properly. If you have enough battery life, if the generator needs to be replaced.
So a lot of facilities have processes in place if someone comes in and they're having symptoms that people may think are their heart or something and they have a pacemaker? Say they don't have like EP on call or they don't have somebody, like what would you suggest for like a nurse working in the ER if somebody has a pacemaker?
So all of the major device companies have a way to interrogate these devices remotely. And there's always someone on call from each of these companies.
Mhm.
And so there's a way that the staff can interrogate the device remotely. You can use a tablet, for example, and that will send all of the information to the rep that's on call, but it can't make any changes to the device. So it's very safe.
Mhm.
It's just a diagnostic tool to send information. So if a patient had an episode or there was an issue that we needed to know about with the lead, then that information can be seen by the representative, and then they can call the emergency department back and give report.
Okay, great. What about surgery? Can patients that have pacemakers have surgery? Is there anything that like nurses need to ask or know beforehand?
Yeah, so if a procedure is happening below the belly button,
Mhm.
and then any equipment that is being used on that procedure cannot interfere with the device.
Okay.
So no changes need to be made. You don't have to use a magnet. Everything is totally fine. So if you're getting bunion surgery, everything's fine.
Okay.
If you're having a procedure that is above your belly button, but
Mhm.
it's not open heart surgery or surgery that is on the particular shoulder of wherever your device is,
Mhm.
then that's where the magnet comes back in. So
Okay.
the magnet can be used to pace the pacemaker at a continuous rate and mode. Pacemaker function for each company is different,
Mhm.
but the overall idea is the same. It will make the pacemaker unable to see any of the electromagnetic noise that could be caused during the procedure.
Okay. And that way the patient can continue to be paced and it's not interrupted because of that noise.
Mhm.
How can primary care providers or hospitalists recognize signs that a patient might need device evaluation or follow-up?
I think this is so important.
Mhm.
So I had a pediatric electrophysiologist, Dr. Austin, say to me once, and it's so true, if pacemakers failed as often as people think they did,
Mhm.
no one would ever get a pacemaker.
Yeah, right.
And for the most part, pacemakers are never wrong. They're just doing what they're told.
Right.
They are fancy computers that we have programmed different values into and limits and parameters to do what we think is best for the patient, but it's not a one-size-fits-all method.
Absolutely not. We optimize it to the individual patient.
So I would say that the biggest thing, let's say you're a telemetry nurse or you're on the floor and you have a patient with a device. If the patient has a heartbeat, this is good.
Yes.
I know that this sounds crazy, but if a patient has a heartbeat and it's not pacing, that's okay. For example, the telemonitors, which a telemonitor is the heart monitor that a patient is hooked up to in the room. Sometimes it's in the room with the patient. Sometimes it can't be seen in there, but someone's monitoring it. And they do their best, but they err on the side of caution. So if they see a very small heartbeat, then it could say that the patient is asystolic or has no heartbeat.
Mhm.
And that happened to me once. I had a nurse call me to say her patient was asystolic. I was new into this career. I didn't know any better, and I showed up. I didn't ask any follow-up questions until I got there. And she showed me the rhythm strip, and yes, it did say asystole,
Mhm.
but the patient was talking,
So not dead.
not dead, and they had a heartbeat, a beautiful, beautiful native QRS, which is what your heartbeat is made up of, at 90 beats per minute. Use your best judgment and be cautious when you see these alerts pop up on the telemonitor, but just take everything in to the situation. Don't forget the basics.
Don't forget the patient.
Yeah.
Check them. Let's talk about remote monitoring now, because it is definitely more common and has been super helpful through the pandemic, for sure, for us to keep tabs on patients. What should non-electrophysiology providers know about how it works and what kind of alerts they might encounter?
So a remote monitor is a great diagnostic tool,
Mhm.
and that's all it is. It's never going to call 911 for you. It's not an emergency device. It's just a way to provide information to your provider, which is great because you need to get your device checked about every 3 months. And that would be extremely inconvenient if the patient always had to come into the office to be physically interrogated by the electrophysiologist or cardiologist staff.
Right.
So there's a way to do that from home. You can even do it from an app on your phone, depending on what type of device and which company manufactures your pacemaker.
Mhm.
But this is a way to provide just diagnostic information to your provider. It cannot make any changes to your device.
Our standard, which I think I spoke about in another episode, is that we get a remote transmission every 3 months, and they come in to have their leads tested once a year and to see someone here, like on our device team. The nice thing about the remote monitoring is if something comes up with a lead or it's starting to show some signs of wear or like maybe malfunctioning, it's going to notify us long before it becomes a huge problem.
Mm-hmm.
And that's the nice thing about being on a remote monitor. Well, it's like you said, it's not an emergency service, but it will ping us and send us an alert, and we'll be able to know that we need to investigate this further, either get the patient in to do some lead testing to make sure, or to watch and wait, or to send them for a chest x-ray to make sure the lead integrity looks okay. It can also send us an alert if you're on the remote monitoring that you're having an arrhythmia that maybe we wouldn't catch if you only came in every 3 or 6 months. We would know that ahead of time. So
because that's another thing that a pacemaker is. It's a diagnostic tool. Like within the parameters that your physician has set, we can see if you're having too fast of heart rates. The pacemaker can do testing on those leads every day, similar to what you would have done by a person if you came physically into the office. So without the remote monitoring, the pacemaker is still working.
Right.
You do not need to be around this monitor all the time. I think that is a misconception about remote monitoring,
Right.
is that it should be around you 24/7, and it only needs to be around you when you sleep. So that information is all being stored inside the pacemaker, and when it sees your home monitor the next time, then it sends the information to your doctor.
And the wonderful thing now about remote monitoring, in the past, it had always been you had to take this little box home and plug it in near where you sleep. And now we're moving towards having apps on smartphones. And then you just plug that in the room where you sleep and you have it. And you don't have to worry about travel because everybody takes their phone with them almost. We used to advise when it was just the box. Different companies call them different things. But the remote monitor at home, we would say if you're going anywhere for longer than 2 weeks, you want to take it with you. But now if you just take your phone, you've got it.
So that someone's always looking out for you.
Yeah, absolutely. In your experience, what has been the most effective way to educate interdisciplinary teams about pacemakers and troubleshooting basics?
I think reaching out to your local reps is always a good idea. They have a lot of resources that they can give to healthcare providers that can go over the basics of a pacemaker. They can go over remote MRI guidelines. They can go over timing of how a pacemaker works, and they vary in different levels of difficulty. So if you want to know about every algorithm in this pacemaker, you could do that. If you want to manage a patient on a basic level, then there are resources for that as well. So there's a lot of education online that you can find about pacemakers.
Yeah, absolutely. And one thing I'd like to say, like, I bet a lot of people don't know who their reps are, and especially like when they're not cardiology or EP. So I would say that your best route through this is to find out who your EP colleagues are, your cardiology colleagues, because not every place, especially rural healthcare facilities, they don't have electrophysiology, but reach out to someone in that department, one of the nurses, the nurse practitioners, the PAs, even the physicians, like ask them, because if you're interested, it's always helpful. It's always great to know more about what's going on around your patients and their devices.
It's always better to ask for more information than to go without.
Because I know one thing too, the reps are really good about education for us as electrophysiology teams and cardiology teams.
That's part of our job.
Yeah.
That's another piece of the puzzle that a rep can do, is to provide education. We all learned how to do this one.
Yeah, exactly. And so if you are a nurse or a nurse practitioner in another specialty, but you have a lot of patients who have pacemakers or defibrillators or some kind of cardiac implantable device, talk to the teams who implant and say, hey, I'd like to know more about it, because there's always like there's lunch and learns. There's all kinds of things that go on that you can jump in on and get some information. And I love teaching people. Like the whole cardiology team is available to come to our device team lunch and learn that I host once a month. A lot of times it can be a little bit deep and not something they want to know. But then sometimes, like right now, we're watching some lectures on some basic things just to like refresh on it. So, that's a really good start for that. Lauren, what do you think people should look at on a device check that would give them the most information if they're outside of EP that they might need to know?
I think they should look at the battery life.
Mm-hmm.
That is probably the most important one. They should look at the percentage of pacing needed.
Mm-hmm.
That can give you an indication of why the patient has the device.
Mm-hmm. Okay. Yeah, I think those are great tips.
You can also look for episodes and when the automatic measurements that the pacemaker does throughout the day, when they were last taken. I think that's really important because just because a value was presented, it's important to see when that actually happened. Was that yesterday or was that 3 years ago?
Right. And every vendor of pacemaker, I think, almost always has that information on at least the first or second page.
Correct.
Okay. What we didn't go over was the history of the pacemaker. Who invented the pacemaker? When was it? Well, when did it start? How long has this thing been around?
So the pacemaker has a long history, going back as far as the 20s. But the pacemaker that we know today was invented in partnership with Dr. Walton Lillehei and Earl Bakken, who was an engineer from Minneapolis. And they created the first battery-powered portable external pacemaker. Pacemakers used to be plugged into an outlet. So you were bedbound, you couldn't leave, you had a heartbeat, but you couldn't go anywhere.
Okay, some quality of life there.
Yeah.
I mean, you had life.
In 1957, they invented the pacemaker as we know it. It has come a long way. So they went from being external and plugged into an outlet to implantable, but they had to be implanted in your abdomen because they were the size of about a softball. They weren't that bulbous. They were flatter than that, but they were about that size. And then eventually they worked their way up to being small enough to put in someone's chest. And now we go all the way to the vitamin-sized one. Right. So they've come quite a long way.
We go from Oreo cookies to vitamins to softballs. So, Lauren, your dad and you have done the same job at this company, but you both have different roles because you are a biomedical engineer and your dad's a nurse, right?
Yeah, he worked in a cardiac cath lab before he went into devices.
So you can be a nurse, you can be a biomedical engineer to be kind of like a device rep for a company. Is there any other like education or thing that people come into this with?
So you can start from just about anywhere with this role. Yes, having a nursing degree or an engineering degree are helpful, but they're not necessary to do this job. I had people in my initial training class that one used to be a car salesman.
Wow, really?
So people come from all walks of life. It's really about how, like, what's your learning style and can you pick up this information? Each company does a really good job of training everyone to be the expert in this one thing. So the training can take about a year, and that's just to get the information. So the first year, you're just training, you're learning everything possible about devices. Your second year, you think, oh my God, I can't believe they let me do this on my own. And then by the third to fifth year, that's when you really start to feel confident in this role. But it really just comes with practice. It's just like anything else. And especially medicine, you just have to see it. It's a very hands-on way of learning.
One of your colleagues that I used to work with and get a lot of education from, she always said, you have to have your hands on the pen because the programmers, that we used to use, now that we all have iPads now, but they used to have like a pen or a stylus that you would like, punch little things on the programmer to do things. And yeah, it really is just that repetition and that experience in clinic. Because even for me as a nurse practitioner, when I am interrogating something, my device team does all that now. I don't have to as much, but when I had to do it, it really was your training that helped me be able to do that. It's very interesting because I think you and I had talked about this when we were talking about this interview, was like, people don't even know that this is a job, and it's a really great job, like, because you get to help people and you get to assist physicians and electrophysiologists and nurses and NPs and device teams and patients. And so you get your hand in it. But like you said, you're not exactly a nurse,
Mhm.
but it's just this nice, like, if you want to be in healthcare, it's a great.
It's a perfect marriage between I like to problem solve,
Mm-hmm.
I want to help people and be in healthcare, and I think that the human body is the coolest machine out there. But yeah, it's a job that nobody knows that it exists, and I get that question a lot in clinic is, "Well, how did you even get here?"
My dad.
Yeah.
When your mom is a nurse too,
Mhm.
so you just come from a background of healthcare.
Exactly.
Yeah. And I think the cool thing too about like cardiac devices and device companies is that like you can do like the clinical part, but you could also be a scientist. Like you can work on the actual like engineering piece of it, which
Mhm.
is really kind of rad also.
There's so many people involved in healthcare
Mhm.
that you just don't even realize are there. So,
Yep.
like within a medical device company, just the medical device company, there are people that do the research, there are people that do the manufacturing, there are people that do clinical trials. And but everything that you come in contact with has had so many people involved to give you the best possible outcome and the best possible care. There are so many people that are involved, and from your physician, the surgeon doing the procedure, your anesthesiologist, staff, the nurses in the room, the techs in the room,
Yep.
the reps, then the people that scheduled the procedure, the people on the clinical side that have nothing to do with the procedure itself, but they still provide care. It's
The team who developed the technology for this device and the battery for the device and the leads for the device. That blew me away. I've been to 2 different manufacturing plants for 2 different vendors, and that was really like remarkable to me. Like I met scientists who are working on this stuff and they don't have any idea about the clinical side, and I didn't know about the science side outside of, well, this is this great device. And it's so cool that it's just amazing different jobs. So it's
yeah,
pretty awesome.
there's a lot out there so that you can still be involved in making people better.
Yeah, absolutely. Well, Lauren, I hope you'll come back in the future because I know we have a lot more to talk about. And I know you recently kind of switched roles and moved outside of devices and are doing something awesome. We could also have you on to talk about that because I know that's going to be something important and still within my field. So I appreciate you being here and I look forward to talking to you in the future.
Yeah, I could talk about pacemakers forever, and one day soon I'll be able to talk about ablation as well.
Awesome. Thanks, Lauren.
Thanks, Nadia.
Thanks for tuning in to this episode of In the Loop with Nadja Wlasiuk. I hope you found today's discussion insightful and empowering. Feel like diving deeper into the topics presented today? Be sure to check out the show notes for references and more helpful information. You can also visit our Substack or Instagram, Facebook, and TikTok. Remember to stay curious and stay informed. Now you're in the loop.